What's up, everybody? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over embryologic defects. So today we're going to be covering two embryologic defects. The first is called a tracheoesophageal fistula, which means an abnormal connection between the trachea and the esophagus. So recall from our previous video, we discussed an embryologic structure called the foregut. And we said that the respiratory system is derived from the foregut. It grows off of the foregut as a little bud called a lung bud. And the lung bud is going to elongate and eventually give rise to a primitive respiratory system. And the part of the primitive respiratory system that we kind of have illustrated here would be the trachea. And the foregut is now starting to become the esophagus. And there's still a connection between the trachea and the esophagus. And normally, this is going to obliterate. Once obliterated, there's going to be two distinct structures side by side, the trachea and the esophagus. Now, sometimes the obliteration doesn't occur in that little connector piece that I just showed previously. Sometimes the obliteration actually occurs above the connection in the esophagus. And what this is going to result in is the upper portion of the esophagus is going to close and become a blind loop, whereas the lower portion of the esophagus is actually going to retain its connection to the trachea. And this is the most common way that the tracheoesophageal fistula forms. Depending on where the obliteration occurs in the esophagus, we can have multiple formations of this fistula. I have on the slide here the first, second, and third most common formations of this fistula. However, this first one here, which is the one that we just illustrated, is the most common for the purpose of board examinations. Now, when the tracheoesophageal fistula forms like this, there are a few high-yield findings that you need to know to answer board questions. The first is that we will not be able to pass a nasogastric tube. Now, why do you think this is? Well, the nasogastric tube is a tube that is inserted into the nose. It goes down the pharynx, into the esophagus, and then into the stomach. And I have that illustrated here. Up through the nose, the pharynx, the esophagus, and then into the stomach. And as it goes from the pharynx into the esophagus, if there's this fistula and it has this formation here, it's going to actually stop once it hits the blind pouch. It's not going to be able to pass the blind pouch, and it won't be able to progress into the stomach. The next finding is something called polyhydramnios. Now, how do we explain polyhydramnios in the setting of tracheoesophageal fistula? Well, let's just draw in a little cartoon baby here sitting in the mother's uterus. And let's recall the cycle of amniotic fluid. So amniotic fluid is produced into the uterus. It is then swallowed by the baby and then peed out. And it's kind of a cycle like this. They swallow and pee and swallow and pee. And if we are unable to swallow the amniotic fluid because it gets stuck in the blind pouch of the upper esophagus, then we are going to end up actually building up amniotic fluid because the baby is not swallowing it, so it's building up exterior to the baby. And that's called polyhydramnios. Now, the next finding is that there's going to be drooling, vomiting, and choking on first feeding. And this one's pretty easy to understand because as the baby is born and then it starts to swallow saliva or food, it's going to go down into the esophagus and it's not going to be able to pass that blind pouch, and it's going to start to build up and then overflow out of the mouth, and that's going to present as drooling and vomiting and choking. And finally, we're going to be able to see air in the stomach on chest x-ray. Now, let's recall that the next portion of the esophagus is the stomach. And so as we inhale air, it's going to go down the trachea and into the lungs, but it can also, if that fistula is present, move laterally into the esophagus and start to occupy space in the stomach. And I have a radiology image on the right here We can see the stomach is right here, and it's filled with all of this kind of dark space, which represents air. And also, if you look closely up here in the corner, there is a nasogastric tube that's inserted as they're attempting to diagnose the tracheoesophageal fistula. All right, let's move on to our second condition here, and it is called pulmonary hypoplasia, which means the underdevelopment of the lungs. And it can be caused by two things that we're going to be talking about today. One is renal agenesis, and the next is congenital diaphragmatic hernia. So if the baby has renal agenesis, or the underdevelopment of the kidneys, it will be unable to urinate in the mother's uterus. And this is going to have a few consequences that are collectively known as the Potter sequence. So let's just go back to our diagram here. If the baby is unable to urinate, then it will keep swallowing amniotic fluid, but it will not recirculate it back into the mother's uterus. And as a result, the amniotic fluid level is going to drop. And as the amniotic fluid level drops, we call this oligohydramnios. Oligohydramnios. And it's the opposite of polyhydramnios that we saw in the tracheoesophageal fistula. So what's going to happen is the amniotic fluid level is going to drop, and the uterus is actually going to kind of cave in on the baby and restrict its growth. And there are two important regions that experience these growth restrictions that are commonly featured on question stems. The first is right here, the nose. So usually they'll tell you that the baby has a flattened nose. And the second is going to be the extremities. So they could have different malformations in the extremities or shortened extremities. Okay, now let's bring it back to the lungs. So let's just draw in our lungs here. And not only is the baby swallowing fluid and having it go from the digestive system to the blood and then to the urinary system, but the amniotic fluid is also going to go down the trachea, and it's going to occupy the lungs, and it's going to open up air sacs in the lungs and allow them to develop and stimulate them to grow. So if we have oligohydramnios, or a low level of amniotic fluid, then this fluid's not going to occupy the lungs, and it's not going to get as strong as a growth stimulus, and that's going to result in the underdevelopment of the lungs, also known as pulmonary hypoplasia. All right, now let's finish off with the congenital diaphragmatic hernia. So let's just redraw our lungs in here. And there's a muscle that is right underneath the lungs called the diaphragm that we're going to be talking about in the next video. And right under the diaphragm, we have the bowel loops. Now, if you can recall from embryology, as the diaphragm is developing, there is a certain membrane that needs to develop in the diaphragm about there, and it's called the pleuroperitoneal membrane. The pleuroperitoneal membrane, and it's high yield to remember this name. And so what happens in this condition is this pleuroperitoneal membrane never really develops or fails to develop. And so I just erased the lungs here as well because this happens very early on in development. And as this pleuroperitoneal membrane never develops, that allows these bowel loops to actually herniate up, hence the name diaphragmatic hernia. It herniates up and it occupies the space that the lungs were about to grow into. And so where there are no bowel loops, the lungs are going to be able to develop normally. However, where there are bowel loops, the lungs have limited space to grow. They cannot grow into the space the bowel loops are occupying, and so they become underdeveloped, which is another form of pulmonary hypoplasia. So that's all I got for today, guys. Hope you enjoyed the video, and join us next time for Muscles of Respiration.